And now I would like to introduce Dr. Andrew Sulich, who will talk from a rheumatologist's perspective on OA.
Hello, everybody. My name is Andrew Sulich. I'm a physician at Shores Rheumatology in St. Clair Shores, Michigan. Today's topic is long-term osteoarthritis pain management with safe, effective use of OTC analgesia. Today I will talk about the profile of the osteoarthritis patient, their type of pain, some of the pain management challenges, including the selections we have for non-pharmacological therapy and pharmacological therapy, including opioids, NSAIDs, and acetaminophen. We'll also talk about long-term considerations around pain management. As a brief background, when OA patients visit a clinician, almost 50% of the time they see their general practitioner. Another 40% of the time they see their internist. So very few patients get to see the rheumatologist for first-line management of their osteoarthritis. Why would somebody refer somebody to a rheumatologist for osteoarthritis? Well, the key considerations, as Dr. Chappell mentioned, are first to rule out any secondary causes, such as underlying inflammatory disease, fibromyalgia, and crystalline diseases that need to be eliminated prior to primary management of their osteoarthritis. Then there are the complicated patients that do not readily respond to initial therapies recommended by their family practitioner or internist. Dr. Chappell mentioned mixed components of osteoarthritis. You may have small and large joint involvement, in which case management may differ. And of course, the presence of an overt inflammatory disease, such as rheumatoid arthritis, can sometimes mask itself as osteoarthritis, particularly in an older patient who has ongoing joint swelling. And of course, there's a procedural role too. We rheumatologists do injections, both corticosteroids and viscosupplementations. Some general practitioners may not. If you're talking about osteoarthritis, the radiographic findings basically support the clinical findings that you see. Most radiographs are designed primarily for prognostic purposes, to see how severe the osteoarthritis is, and of course to rule out any secondary causes. So in this slide, you see the kind of depiction of the osteoarthritic joint. What are the cardinal features that you see? We see joint space narrowing, we see hypertrophic bone formation. There, at the third PIP, or proximal interphalangeal joint, you see joint space narrowed. The patient has developed large subchondral cystic changes and thickening of the bones. This gives us an insight as to the pathology of what's happening. You're having gradual deterioration of the underlying cartilage, and then, of course, there's reactive changes happen in the bone. Kellgren-Lawrence classification can be devised by the X-ray. You can see 1 through 4. There you have a grade 4 at the third PIP joint, where you see almost complete joint space narrowing. And now you have the proverbial bone-on-bone scenario. Pain is the most debilitating presentation of osteoarthritis. It is the most common complaint. It doesn't always correlate with X-rays, so we shouldn't always look at X-rays as a measure of their pain. More so, look at it as a prognostic factor. If we look at contributors to pain, why do patients get pain? Well, you can have raised intraosseous pressure or articular pressure because the synovial capsule may be expanded with joint fluid. We also see proliferative synovitis. So in osteoarthritis, even though we were taught it's not an inflammatory condition, we now know there is an element of inflammation. And so you see synovitis, bursitis, and sometimes tenosynovitis, which can be associated structurally around the joints. There's also muscular imbalance. Patients develop secondary muscle weakness and develop contractures. So they may contribute to some of their pain as they ambulate or as they grasp with the involvement of the hand. There are also social factors as well. We have to think about patients who have depression or patients who have sleep abnormalities. There are multiple factors which contribute to osteoarthritic pain, and they're not always readily treated with just a simple approach. Now, in talking about osteoarthritis-related pain, it's important to have a bridge of communication with the primary care physician in order to align management options. As a rheumatologist, there are several ways to look at evaluating the patient and implementing therapy. The first is to estimate the patient's risk factors. We do a functional risk assessment for comorbidities and common medications, sleep disturbance, and some of the costs associated. This is a kind of complex evaluation that is usually done when the patient is first seen and can help determine treatment options. We try to educate patients on weight reduction, muscle strengthening, and orthotic use, as Dr. Chappell mentioned earlier. The third thing is engaging, which means pharmacological therapy. As rheumatologists, we have to exclude any other causes. We have to make sure that we're not missing anything. Then we have to encompass all aspects. Are we going to try local modalities? This includes topical agents, steroids, or hyaluronic acid supplementation. Finally, if we've exhausted all modalities, enrolling patients for surgery is the next step, especially if patients are not responding to conservative therapy. What are the options in terms of pharmacological treatment for our patients? One of the common therapies for management of osteoarthritis is opioids. They're available by prescription and are restricted. They're effective analgesics, and in my opinion, they're very helpful for nocturnal pain. But they also have limitations, which are the potential of addiction, misuse, and abuse. They're also concerned about some of the nuisance side effects of these drugs can have on somnolence and, of course, constipation. They also can have extreme side effects such as respiratory depression. And because dealing with primarily older patients, we have to be careful about the type of dosing that we're using with opioids, their half-life, and again, the age of the patient. When looking at potential challenge with opioids, we have to consider that some of these patients are on antidepressants or sedatives. Of course, alcohol consumption can sometimes contribute to some of these depressive effects. If we're going to use these agents, we should think about recommending limited or short-term use of these drugs, considering all the side effects such as constipation, sedation, addiction, and respiratory depression. And again, while thinking about all this, balancing the efficacy and safety. So when opioids are being used, we should use the lowest effective dose and use the short-acting agents first and require drug monitoring. That requires a long-term commitment from either primary care or the rheumatologist in terms of monitoring the drug. Opioid contracts, which are, I think, essential in most patients who are going to be taking long-term therapy. In mitigating the risk of opioids, one question is, when do you wean people off opioids, especially if they've been on long-term therapy? It is usually when the risks outweigh the benefits. It could also be for some of these nuisance side effects, or in cases of suspected abuse, non-adherence, or polypharmacy. There are many weaning strategies that we could utilize. One method I use is to decrease by 10% of the original dose when weaning them from long-acting agents first. Make sure that they have enough short-acting agents on board, and careful of the long half-life agents, because one of the concerns we have is withdrawal. Patients may withdraw with various types of symptoms, such as nausea, diarrhea, muscle pain, irritability, and insomnia. When it's difficult to wean the patient from opioids, we can think about counseling, if possible, even chemical dependency counseling. But again, the key thing is slowly withdrawing therapy and, of course, monitoring for some of these side effects of withdrawal. There's also non-opioid pain management options to consider. One option is NSAIDs. The potential challenge for NSAIDs, particularly in my practice, would be the inherent risks not only with regards to prescription NSAIDs, but over-the-counter NSAIDs. Many patients do use polypharmacy. They utilize NSAIDs for different measures, such as headaches or back pain. So in treating them for osteoarthritis, a good history has to be obtained, including considerations Dr. Chappell mentioned earlier. Another thing to think about is drug-to-drug interactions and exacerbating conditions. We know that NSAIDs can interact with certain medications, and there are concerns with using anticoagulants or agents with renal consequences. There are particular concerns regarding GI toxicity because of the morbidity and mortality risks. It is also important to understand that the subtle toxicities that we're just beginning to address, which include the cardiovascular issues associated with the use of NSAIDs. If you're caring for patients with any of these risks, they need to be evaluated. You may not want to utilize an NSAID in this situation. There are also risks with concomitant medication use. One example that has been described in the literature is aspirin ibuprofen. This is because aspirin is utilized with many patients as an anticoagulant, and ibuprofen temporarily blocks aspirin from binding to its target, reducing its efficacy. There have been reported cases of patients developing cardiovascular complications, particularly stroke, when using ibuprofen first, followed by aspirin. This should be discussed with the patient if they're on low-dose aspirin. There are also tolerability issues to address, such as gastrointestinal, edema, and hypertension, which also needs to be monitored. In general, for NSAIDs, the American Heart Association recommends using the lowest effective dose for the shortest period of time. How do you mitigate risks associated with NSAIDs? We can't stress enough that the full history has to be obtained with patients in terms of looking at their risks. Do they have hypertension? Do you have underlying renal disease? Do you have liver cirrhosis? In some patients, the GI consequences can be reduced by using proton pump inhibitors. Notice the word is reduced. It is not eliminated, and proton pump inhibitors won't diminish the cardiovascular and renal complications of NSAIDs. Some patients may use topical NSAIDs. These treatment options are attractive because they're localized, but can be expensive, whether they're prescribed or compounded. So again, the healthcare provider, whether using NSAIDs, even though they are effective for osteoarthritis, should focus on using them for the shortest period of time while looking at the risk factors for each individual patient. What about acetaminophen use in pain management? Again, just like NSAIDs, OTC acetaminophen is not a disease-modifying drug. It is effective for pain management. Although it's typically used for minor aches and pains, it is a cornerstone of treatment for osteoarthritis. You can use the drug up to 4,000 milligrams per day, which is the maximum daily dose, to address the intensity of your patient's pain. We should also be mindful that patients may be taking other acetaminophen-containing products, possibly including opioid acetaminophen combination agents. It is crucial to obtain a complete history. Keep in mind that acetaminophen has been shown to be safe up to 4,000 milligrams when taken as directed. So then we ask, okay, how is acetaminophen useful for pain management in osteoarthritis? In multiple clinical trials, it has been shown to be safe and effective, even for long-term use up to 12 months. We see that the majority of patients had normal ALT, AST levels when using acetaminophen. Even with minor elevation in these levels, we have not seen any hepatic failure within these studies. There are many advantages of using acetaminophen and is among the first-line choices of analgesia. It remains the hallmark and cornerstone of therapy in patients who have osteoarthritis. What are the potential challenges of using acetaminophen? There's potential for acetaminophen to elevate liver enzyme levels. However, it isn't clear whether these elevations are clinically relevant without other laboratory abnormalities. According to N. Haynes' study, 9.8% of the general population has elevated ALT or AST levels, and this variation can be attributed to demographic factors such as age, gender, race, and ethnicity. Also, there are always the concerns of acetaminophen overdose, which can lead to acute liver failure. Acetaminophen overdose is rare, as data suggests that 95% of acetaminophen users actually take it appropriately. It is important to talk to patients about what other products they're using that may contain acetaminophen. Engage them as to how much they're taking overall. That's really the challenge, because many of these products are over the counter. So it's not something that's going to show up in your EMR as a prescribed product. The critical aspect is discussing other medications the patients are taking, the dosages and the frequency, and to emphasize that patients shouldn't take more than 4,000 milligrams per day. The key is patient education. So let's bring together everything we've talked about today. If you look at an overview of OA pain management, you begin by assessing the patient profile. This includes identifying concomitant medications and comorbidities. Also keep in mind that pain management is not just pharmacological therapy, but physical therapy, identifying localized treatments, and non-pharmacological therapies. When you introduce pharmacological agents, acetaminophen should be strongly considered as first-line therapy for osteoarthritis. Increasing analgesia, depending upon the severity of the osteoarthritis and the lack of response to initial therapy, may include nonsteroidals and opiates. And if you're going to use long-term opiate therapies, one must consider the risk versus benefits and wean them when the risks exceed the benefits. For those patients who do not respond to our typical treatments, who have excessive comorbidities, who have exhausted non-pharmacological and pharmacological therapies, the last resort option is then surgery.